Thank you, and thanks for being here today. This is such an important topic, for our state. I'm going to give you just a brief overview of Medicaid in general and how Medicaid affects state budgets, and particularly Michigan state budgets, and how Medicaid works. And I think the first thing I want to emphasize is that just because you get a piece of paper that says you have health insurance doesn't mean that you're actually getting health care. Health insurance is not the same thing as health care. Let's go to the first slide here. So, Diamante Driver was a young boy, 7th grader, who lived in the poor suburbs of Washington, D.C., in Prince George's County, Maryland. And he was, in 2007, he died of a toothache. And there was an article in the Washington Post at the time that said, this is the reason we need to have the Affordable Care Act. This is the reason we have to have health reform, is because we want to live in a country where 12-year-olds like Diamante Driver don't die of toothaches because they're poor. But the interesting thing that the article failed to note is that Diamante Driver wasn't uninsured. He was on Medicaid. He was insured by the government. And why Diamante Driver died is a story that illustrates a lot of what is wrong with the Medicaid program today. Next slide, please. So, the biggest problem with Medicaid, and there are many, but the biggest problem with Medicaid is that as states, because the program is jointly funded by states and the federal government, states have, because of the budget crises, tried to cut back on their Medicaid programs. They've had to, because the program has grown and grown and grown and grown. But states don't want to cut poor people off from the program. And so if you don't cut poor people off from the program, and you don't raise their premiums and their copays, there's only one avenue left for you to keep your Medicaid budget under control. And that's to pay doctors and hospitals less to offer the same care at the same price to the patient. And so what has happened? In Maryland, fewer than 1/6 of Maryland children have ever had a cavity filled. For every dollar that a private insurer pays a doctor in Maryland to see a a privately insured patient, Medicaid only pays 66 cents. And so for a lot of physicians, they face the choice, even if they want to treat those Medicaid patients, they face the choice of closing down their practices or losing money or shutting their doors to Medicaid patients. And so a lot of them do. They turn away Medicaid patients. They only see people with private insurance because Medicaid pays less and less every year. And so you have this piece of paper that says you have health insurance, but you can't see a doctor, not just for routine things like getting your cavities filled or getting your annual checkups. But there was a study in the New England Journal that showed if you're a kid on Medicaid and you have an acute asthmatic attack, you have a serious injury like a broken wrist, half of doctors won't take you. They won't see you. Half of doctors, these are specialists we're talking about now, because Medicaid pays so little that a lot of physicians don't take it. Next slide. Next slide. So how about Michigan? So in Michigan, the problem is even worse. I told you that in Maryland, for every dollar that a private insurer pays a doctor to see a patient, Medicaid pays 66 cents. In Michigan, it's 47 cents. And this is 5-year-old data. This data is from 2008. So these numbers have gotten worse over time. The gap between what Medicaid pays physicians and what private insurers pay physicians has only expanded. And the pressure on physicians to abandon Medicaid patients has only increased. Next slide. So this is the most important chart I'm going to show you today. And that's, it's a busy chart. I know it's hard to read if you're in the back there. But basically what this chart is looking at is the percentage of physicians who accept no new patients by insurance status. So you'll notice here this dark blue in the front, this is by specialty, all these names here. The dark blue in the front shows you that if you're on private insurance, which is the dark blue, your chances of getting rejected by a physician who you want to see is 5%, under 5%. If you're on Medicare, our program for the elderly, that's the light blue, it's about 15%. And that number is getting worse over time as Medicare lowers the reimbursement rates to doctors and hospitals. But for Medicaid, it's 30% and growing. And again, this is 2008 data. So this is getting worse and worse over time. You have a piece of paper that says you have health insurance. but that doesn't mean you can actually see a doctor when you need one, or even when you don't need one, when you're just getting routine preventive care like an annual checkup. Next slide. So this past spring, something really important happened. The New England Journal of Medicine published a study, the gold standard, the best study ever published. It was a randomized controlled experiment in Oregon, where because Oregon had to expanded its Medicaid program recklessly and then had to roll it back, instead of rolling it back based on traditional consideration, they said, we're going to have a lottery. They literally had a random lottery where if you won the lottery, you could sign up for Medicaid, and if you lost the lottery, you'd be uninsured. And some smart economists from MIT and Harvard said, let's look at this as a controlled experiment. Let's see how the Medicaid patients do in terms of their health versus the uninsured patients. This will allow us to prove that Medicaid is actually helping people. What they found was that, and this is a direct quote from the article, Medicaid generated no significant improvements in measured physical health outcomes versus being uninsured. Now, this is despite the fact we spend $450 billion a year on Medicaid. It showed no benefit on diabetes. It showed no benefit on blood pressure. It showed no benefit on cholesterol. It certainly showed no benefit on mortality. So all the things we think that health insurance does to help people, you know, a lot of people will say, well, we've got to expand Medicaid because people's lives are at stake. It turns out that Medicaid actually does nothing to improve the health of people. And it's not because insurance doesn't help people, or that health care doesn't help people. It's because this program is so poorly designed that you have this card that says you can get health insurance, that you can get health care, but you can't actually see a doctor when you need one. Next slide. In Michigan, 45% of next year's state budget is health care. This is the rest. The blue is the rest. The yellow is health care. And this is growing every year. And if you do the Medicaid expansion, it will grow even more. Right? So you're squeezing out everything else that the state government does. This 30% number, that's education. 12% jobs, 6% public safety, police, fire, 5% government services, 2% environment, 1% budget stabilization savings. 45% is health and human services, the bulk of which is Medicaid. And so when you expand Medicaid, if the costs grow at a higher rate than you expected, then what you're really doing is you're forcing all these numbers to get smaller. Teachers' salaries, fire, safety, highways, all the things that we traditionally think of state government's responsibilities as being, will have to shrink. And Detroit and Michigan, of course, are not places that have a lot of money to spare to fund extra liabilities on health care. Next slide. So here's one of the key things to understand. You hear a lot of people say that we got to expand Medicaid because it's federal tax dollars that are going to come in and fund this expansion. The state is getting a great deal out of this. But it's a bit of a teaser loan. So in the first 3 years, the federal government, that is to say federal taxpayers, pick up the whole tab. But as time goes on, the federal contribution shrinks, and it declines to 90% from 2020 and thereafter. And you may think, well, the federal government's still funding 90%. That's still pretty good, right? And the way I try to explain it is it's like somebody says to you, there's a $30 million house down the corner, and I'll cover 90% of the mortgage if you can pay the other $3 million. Now, if you've got $3 million to spare, you can afford a $3 million mortgage. That's a great deal for you. But if you can't, you're still going to go broke. And that's the problem, is Medicaid is such a large program that even spending 10% on the expansion for the state of Michigan is at least a $7 billion unfunded liability, despite the near-term windfall. Next slide. And as I mentioned, by the way, the last bullet on that last slide, Congress may reduce the matching rate. So they say it's 90% in 2020 and thereafter and forever. But as we know, the federal government is not, swimming in money either. And if they reduce that match from 90% to 88% to 85% to 80%, then Michigan's liabilities will explode. So here's the thing that Governor Snyder and a lot of other people say, this is why we should do this Medicaid expansion. In the first 5 years, the state of Michigan will get a net benefit of about $1.1 billion from the Medicaid expansion because the federal government is covering the entirety of the bill. Next slide. But what you'll see is that basically forever thereafter, sorry, I don't want to hit you in the eye with my laser there, but forever, basically, after those first 5 years, it's red ink as far as the eye can see. It's a small number at first, 113 million, then 325 million, and it goes on and on. As I said, if you calculate it out to 75 years, using very, very conservative numbers, if Medicaid grows at 2% greater than inflation, and it usually grows at much higher rates than that, but if it's only 2% higher than inflation, then it's a $7 billion unfunded liability for the state, which it will have to make up by cutting other services or raising taxes, one or the other. And again, Michigan isn't exactly a low-tax state today. So this is red ink for as far as, it's great if you're in office from 2014 to 2018. Then you're going to look great. But for everyone who lives in this state thereafter, it's going to be red ink as far as the eye can see. Next slide. And as we know, history shows that, and that last slide, those numbers that I gave you there, those are from a University of Michigan study of the Medicaid expansion. So those aren't the legislature's numbers, those aren't my numbers that I made up, those are University of Michigan's numbers. But as we know, these numbers are, these are projections, these are predictions. They often go wrong. So in 1965, when we created the Medicaid program under Lyndon Johnson, the government projected that in 1990, inclusive of inflation, we'd be spending $12 billion a year on Medicare. In 1990, we spent $110 billion on Medicare. We're about to start spending $1 trillion a year on Medicare. Why? Because once you create this subsidy, people reorient their incentives. They reorient their incentives around attracting the subsidies and around avoiding the tax increases that go with the subsidies. So you often find that the spending is higher than the government projected and the tax revenue is lower than the government projected. And we see this already with the Affordable Care Act. So right here, and again, this is hard to read from the back, but these three numbers, these three bars, are three different times the Congressional Budget Office estimated the costs of the Affordable Care Act. This is the first, this is in March 2010 when the bill was passed. This is in February 2011, like a year later, and this is July 2012, so 2 years later. And you'll see that the cost of the bill kept going up every single year, and the deficit reduction of the bill went down every single year. Because even though the law has barely been implemented, it's already true that the law is costing more and returning less in tax revenue than it was projected to at the time that it was passed 3 years ago. Next slide. Another thing to understand about Medicaid is that it imposes a silent tax on people with private insurance. So we think of this, well, it's a great deal because the federal government's spending all this money. Well, here's the thing. Not only will Michigan's own taxes or spending in other areas have to go down or up, depending, to accommodate this expansion of Medicaid, but people with private insurance will see higher premiums because Medicaid, as I mentioned, pays doctors and hospitals a lot less than commercial insurers do. And historically, what we've seen is that when government insurers pay less, private insurers are charged more. So hospitals and doctors compensate for the fact that the government insurers pay less by charging higher rates to people with private insurance. So you're almost certain to see, as Medicare and Medicaid expand, because of course Medicare is expanding because baby boomers are retiring, and Medicaid is expanding because of the Affordable Care Act, you're going to see a huge increase in the rates charged to private payers to make up for the fact that government payers are paying less. And this is an important point. You hear hospitals. Hospitals are lobbying heavily for this Medicaid expansion because it's extra dollars for them. What they don't tell you is what they will do to compensate, because Medicaid will pay them a lot less money to care for those patients. Hospitals on average in Michigan lose money caring for Medicaid patients. So you expand Medicaid, you put more people on Medicaid, hospitals are going to lose more money. What are they going to do to compensate for that? Charge people with private insurance more. Next slide. This is the other thing about uncompensated care. So again, we hear this thing about uncompensated care and how this is such a serious problem. It turns out, as a percentage of national health expenditures, you know how much we spend on uncompensated care in the emergency room? 1.79%. And of that 1.79%, only a third actually is addressed by the Medicaid expansion. So the fact is, the Medicaid expansion only addresses 0.76% of the amount we spend on health care. So you'll hear this line, well, we've got to deal with the uncompensated care problem because your premiums are higher because of uncompensated. That's not true. It has almost no impact on private premiums. What does have an impact is what I showed you on the last slide, which is when you expand government health care, private insurers are charged more by hospitals. Next slide. So what do we see in Massachusetts? In Massachusetts, when they went with Romney Care in 2006, they found emergency utilization didn't go down, it went up. It went from 2.9 million visits in 2006 to 3.1 million visits in 2010, and it's kept increasing since then. Next slide. Not only that, but we spent more on health care. So you hear this thing about how uncompensated care is a silent tax that makes your premiums go up. Well, Massachusetts did lower their uncompensated care spending by about $250 million a year. But over that time, they spent $800 million a year on additional subsidies for health insurance. So taxpayers in Massachusetts paid more, far more, 4 times more than they saved from lower uncompensated care spending. Next slide. So this is the situation in Michigan. If you expand Medicaid, you're going to see this purple is the stuff are the people who are going to be covered by the Medicaid expansion. These are the people who are going to be covered by the exchanges in the purple. The green are the people who are going to be covered by the Medicaid expansions, and the blue are the people who are already covered by the existing Medicaid program. And this is the Medicare population here. Next slide. If you don't expand Medicaid, eligibility for the exchanges drops down to 100%. And that's really important because about a third of the population that we think of as a Medicaid expansion population would actually be eligible for the exchanges under if you decline to expand Medicaid, or you do something other than expand Medicaid, if you use some other approach that doesn't involve the traditional Medicaid expansion. So you can address a lot. That's 100% federally funded with private insurance. Next slide. So we're going to talk, and we've already heard from Senator Colbeck, you're going to hear today about alternatives to expanding Medicaid. The key need is to give these people primary care. That's what they don't have today. Give them a chance to have primary care where they can see a doctor to address their heart conditions, their high cholesterol, their blood pressure. Some states have done this, next slide, like Indiana and Florida, and there are other examples we can learn from. But the key need is to address primary care, to give these people access to care, not access to a card that suggests they have health insurance. Next slide. And let's keep these individuals in mind. You can say that you have a card, but unless you have access to health care, it's meaningless. So let's find a much more efficient way to do that, and we can. Thank you very much.